do you think the government of India will release?
How do you go about in solving this?
Did you receive any feedback from somebody?
A big leap from the normal thing that happens.
Yes.
On the environmental science curriculum for
Kusangpo, and a very warm welcome to the Current Affairs program. And today in our discussion we'll be talking about the measles catch-up campaign, which is currently underway, being conducted by the Ministry of Health. And to talk about this, I'm joined by Somon Chu, the Chief Laboratory Officer from the Royal Center for Disease Control, Department of Public Health. And then I'm also joined by Sange Funso, the Program Officer. He's also from the Department of Public Health. Welcome to the show. Now, to start with, first of all, what is measles, and if you could talk a little bit about its symptoms.
Okay, thank you very much, and I think it's a very good opportunity that we are given, especially to talk on the measles catch-up campaign and why we are doing it at this juncture. So it's very timely that we are today here to sensitize the people on this catch-up campaign. And about the measles disease, and this measles disease, I think it is there since the human beings lived, so it is with us human beings. So the measles is unlike the most other disease. It's not that severe actually. So usually the common signs and symptoms is people often come with a fever, then most will come with a cough, nausea, and then conjunctivitis. So these are 3 or 4 clinical symptoms that people will present to the doctors or even people will know. But what we are worried is especially in the children. If people are not, children are not immunized, there is a complication associated with measles. So first, it is often the children get pneumonia. Then the second one is we call encephalitis, that means something to do with neurological disorders. Then other one is the blindness it can cause. And then other common thing is we often talked about otitis media. Even we had a conference last year to advocate on that. So these are common signs and symptoms and the complication that not only the children but even the adult may present. So this is something people have to be aware of. And most people, they think there is something to do with the flu, and they don't visit. Especially in children also, the patient, parents, they don't give the importance when children suffer like this. They think it's like a flu, and they just keep back in home. I think what we would like to sensitize people is, please, if there's any such signs and symptoms, make sure that the child gets visited hospital. Even the adults yourself should go and visit and seek the medical care.
Yes. But then why the catch-up campaign is conducted at this moment?
Yes, thank you very much. When it comes to conducting a measles catch-up campaign, it doesn't mean that we did not have any vaccine in the country. So we have a measles vaccine since 1979, and then from 2006 we have been providing second dose of measles. Still 2006 there was only single dose of measles vaccine, and then we had a mass nationwide campaign for measles and rubella in 2006. So most of our cohorts in the country are being covered. However, as per our data and then reporting mechanisms through the robust surveillance system that we have in the country, there are cases reported since 2015. By the way, we did not have any indigenous measles cases since 2012. Last case was reported in 2012, and then after not having measles cases for 2 years, 2013 and 14, we started having measles cases from 2015, 16 and till this year. So we felt that there is some immunity gap, and then through the laboratory testing and genotyping and all other investigations, it was revealed that all those cases were import-related cases. It was imported from other countries, I mean India, imported cases. So in order to close up the immunity gap and in order to boost the immunity level of the population in the country, we are prioritizing to not really high risk, but those people who are residing around the border areas, and then the areas where the routine immunization services are not reached. So these are the areas that we are prioritizing to provide the vaccination through this catch-up campaign, basically to boost the immunity level of the population for measles and rubella.
So, sir, does it mean that it's a nationwide campaign, or do you all have a selected group of people targeted for this?
At the moment, it's not a nationwide. As Sangya was saying, it's basically a targeted area. I mean, if you have resources, you would wish to do a national campaign, but with the limited resources, especially to procure the vaccine. So what we have done is we try to prioritize the first the Dzongkha, and even within the Dzongkha, we have prioritized the area. So that again, these are all based on our evidence, through our surveillance, through our research. So we feel that just now, given the resources and the vaccine we have, I think it should be prioritized and looked into those, especially from where the cases have been reporting last 3 years. And as per that, we have prioritized the Dzongkha district, and then according to that, again, we had a lot of consultation with the district health authority, and then we have prioritized the area also. So based on that, now they are going ahead with the campaign. So just now, just for information, I just want to let you to caution that it's not nationwide, so all the people in the country will not get, but the identified area, place where we have identified that area, everybody who are eligible as per our criteria, they should go and get the vaccination. And I'm sure by that time, I think that concerned district health authority would have already communicated to that, but through health BHUs and through health network, they would have communicated it.
Yes. So which means the people are aware of this campaign going on.
Exactly. We have been advocating through our health channel, I mean through the existing health system networks. We had 2 consultative meetings with the district health officers, and then when they go back, they already had a micro plan in their respective districts. They have identified their catchment area, including the contact numbers of the clients, the individuals, so they can immediately follow up. So through that, they have informed accordingly to the respective basic health unit in charges in their respective districts, and then basic health units are closely working with our local government leaders, Chokpa, Gap and Mami, even including the village health workers in the communities. So when they have a micro plan drawn, so these were done basically in consultation with the grassroots level, like community people. So now they know where they are supposed to get the vaccine, and through different mechanisms, we have also provided the vaccine through routine health facilities, through the health facilities. But for this catch-up campaign, we are also identified many more vaccination posts, additional vaccination posts, vaccination sites, and it's accordingly communicated to the clients. So through that channel, they will be getting the vaccine.
Yes. So you all have a targeted population and age group as well. If you could elaborate a little bit on this.
Yeah, for this catch-up campaign, our targeted age group is from 9 months to 40 years. 40 years. So if I just a little bit clarify on this, because a lot of people, including our health workers, there's a confusion. Why not the other range of age
group?
So why we have decided on this in consultation is the World Health Organization is through our evidence, through the case that we got a report, we feel that the 9 months, because that is also the current immunization schedule. So if you give below that, I mean you can still give, but because of the immunity that children won't have well developed, so there will be not a good vaccine efficacy in them. As such, anyway, when children are born, at least 6 months, the children is likely to have the maternal antibody with them. So this will protect them from the infection. Yes. So that's why we kept 9 months as a minimum, and the maximum range we have kept 40 years, assuming that when we have introduced the measles vaccination, that is in 1979, assuming that introduction of vaccine, and I mean then when we had no vaccination, or even in the olden days when the measles was endemic, we assumed that a lot of the age above 40 or plus would have already had a natural infection one point of time, and they would already have natural immunity. So we thought that it's not that necessary. Even our surveillance pointed out that a lot of cases are not reported above age 40 plus. That's why we are considering the age range between 9 months to 40. And also, I think especially the recent cohort, that means last 9 to 10 years, if you looked into our surveillance, we had a very less measles case reported. Nice. So that means there was not much infection going on. Nice. So in that way, there are a lot of immunity gap build up. Because last measles catch-up campaign we have done is 2006, I think. After that, we have not done. So because of that, I think there are a lot of immunity gap built. And also, I just wanted to highlight here is, even if you get the 2 routine vaccine immunization schedules, it's unlikely that 100% will be protected. If you get only one dose, still I think there is a possibility 15% you won't be having immunity, enough immunity to protect against the measles. And even after second dose, still even if you get a 2-dose vaccine, 5% is still likely to be immunity fail. That means because seroconversion failure. So that means they are not protected, though they have got a vaccine. So because of that, a lot of the cohort have built up. Now we have reached, I think, the time where we have a lot of susceptible population. That's why I think when we had the one cases, then it spreads like a fire, and then we had a lot of outbreak in especially in last 2015 and 16.
Yes. That time you talked about not having any indigenous measles cases in the country. What does this mean now?
Bhutan is also working towards measles elimination target because 11 countries in the Southeast Asia region have set the target. For the regional elimination goal, it's 2020. However, Bhutan, we set our target, we were a little bit ambitious. We set our target by 2018. So in that elimination definition, so it's interruption of the indigenous transmission. So here comes the indigenous cases. So we did not have indigenous cases since 2012. So those cases which are reported, positive cases so far, last 3 years, are all import-related cases. So however, those import-related cases, we are much more concerned about the import-related cases. So that's why, in order to close the immunity gap, as Sarah rightly mentioned, we have accumulated susceptible population over the years. Though we had a long history of vaccination program in the country with high coverage for last several years, there is still a susceptible population because of the vaccine itself. Because with 1 dose of vaccine, the efficacy is only 85%.
Yes.
Even with 2 doses of vaccine, the efficacy is above 95%, which means we still have a susceptible cohort of like 5% with second dose. And then we don't have very high coverage. I mean, the second dose coverage is always less than the first dose coverage. So those susceptible population is getting accumulated over the years. So in order to close that gap, so we are having this MR catch-up campaign, basically to build the immunity within the population in those areas.
Yes. Now, when you talk about measles elimination, now Bhutan is one of the 2 countries that has been recognized as measles eliminated in this before target, like the Southeast Asia region. So if you could talk a little bit about on what basis was Bhutan certified as a country who have eliminated measles?
I think it is only recently, I think this year in April, I think there was a meeting held in Colombo. I think after the target, regional target, Southeast Asia regional target, they said that they will eliminate the measles by 2020. Based on that, they already have a commission form to look after, to oversee this and also verify the status country. So based on that, I think last time meeting that were held in Colombo, I think they are meeting for the second time.
Yes.
And in that, before they meet, I think there's already a groundwork done to look into the member states, who are actually at what stage, on the measles status. So they found that Bhutan and Maldives, I think we have already sort of achieved very good high immunization coverage, for years, for last 10 years, and also we didn't have the cases, indigenous cases reported, and because of that, I think the WHO Commission, Measles Verification Commission, has considered these 2 countries to look into for the elimination. So based on that, I think there are a lot of review. Also not only by our national but also WHO, that independent reviewer, they have visited, they have evaluated our surveillance system and also the report that we have. And based on that, although we are getting the measles cases, we just now is import related, it's not indigenous. So WHO, the criteria is if we do not have indigenous measles transmission in the population within last 12 months, then I think the WHO says that we have successfully interrupted transmission. Yes. So that is the criteria that they are keeping in mind, provided with a good surveillance system, high immunization coverage. So based on that, I think these are the 2 countries actually in principle, or actually we are declared as measles free. Yes. But then certification formal will happen at the upcoming regional WHO regional meeting.
Yes.
Just to supplement on what Saras mentioned, WHO has number of criteria to do the assessment before we get the certified as a measles free. Number 1 they look at is incidents, diseases that are prevailing in the country. So Bhutan has been prioritized as low risk area. The incidence itself is very low because we did not have indigenous cases since 2012. And number two, they look at the vaccination coverage. Measles is very infectious, so if you don't have a population immunity, it spreads like 1:18. So very infectious. That's why they look at the immunization coverage as the second indicator. And third indicator, they also look at the laboratory capacity. Do we have adequate laboratory facilities? Do we have a capacity in the lab to do the laboratory testing? So we have WHO accredited lab. The Royal Center for Disease Control and Prevention is a measles and rubella WHO accredited laboratory. So we have a very functional and very well established laboratory for measles and rubella. Then the final criteria they also look at is surveillance system. So do we have a robust surveillance sensitive enough to pick up all suspected cases? So we have adequate indicators within the surveillance system, and then we had officials from Global Verification Measles Verification Commission who visited Bhutan and did the assessment, and we have the report and the recommendations accordingly. We also had regional verification committee members from WHO Southeast Asia Regional Office who came to Bhutan, visited Bhutan and visited some of the health facilities to do the assessment based on their criteria, and that's where now they are concluding Bhutan and Maldives could be the first country in the region among 11 countries which can get the certification.
Yes. Let's talked about vaccination coverage. Now, what's the coverage as of now?
We, for the last several years, we have at the national level we have above 95%. Last year we have 97% coverage for the national level. Specifically for measles and rubella, we have around 96% measles and rubella first dose, and we have little bit less, 93% measles and rubella second dose, because we have first dose given at 9 months and second dose given at 24 months, at 2 years. So that is the routine immunization services provided through the health centers. That is the routine. So first dose coverage is little higher than, always higher than the second dose coverage. We are trying our best to now identify each district with lower than 95% coverage, because by WHO criteria we should have more than 95% measles and rubella coverage for all districts. We are not talking about the national coverage now. We are going down to the district level. So even if we have at the national level, if we have 97% coverage, if the districts are not having 95% and above, we might have to strengthen that particular district. We have already data in our hands, and we have already have a micro plans to enhance the measles coverage in all the 20 Dzongkhags. Most of the districts have already achieved above 95%, and we want to sustain that.
Now, sir, looking at the current scenario, now we have achieved the measles-free, we are declared as measles-free beyond the set target. But can we ever eradicate the disease now?
Now, in terms of eradication, of course, I mean, globally they are working towards that, and I feel among the 6 WHO region, I think, especially the PAHO, the Americans and European, they have already that region has already eliminated measles. Then other 3 are yet to do, and Southeast Asia, our target is 2020. Yes. But again, I mean, we will have to see whether other member states can really achieve. So if all the WHO region or member states can eliminate, then I think then the WHO can think of eradications. It's not possible, but I think it needs to have a very long, proper planning, and every country needs to work. Especially, I think, with the given situation in Africa, with a lot of war and famine, where the measles vaccination, not only measles, others, where it is very poor coverage. So just now, is I would say it's premature to really talk on the eradication of the measles just now. But it's possible.
Yes. Currently, what are the challenges that you all foresee?
The biggest challenge in terms of measles elimination initiative that we are undertaking is the import-related cases. As I mentioned, we started having a number of cases which are imported from the neighboring countries. We have a close border, porous border with India, and then Bhutanese people are also living across the border. So not only in one area, but we have several bordering areas where the importation is occurring. we are targeting to those areas particularly now, and then we are trying to have a detailed micro plan and separate strategies to cater to those areas, to those people residing in those border areas. That is the number one challenge. And number two, to sustain the measles second dose high coverage, because we have first dose given at 9 months and second dose given at 24 months. So second dose, when we have a more longer interval period, the dropout rate is higher. So we are targeting to those dropouts through the micro planning at the health center. All the health centers in the 20 districts are supposed to have detailed micro plan at what time, at what distance, who are the target clients for second dose. So through that mechanism, we are trying to address the dropout for second dose as well.
But do you all have like trained health professionals to deal with this campaign now?
Yes, I think because anyway the measles and rubella vaccination is a routine, you know, they're already doing it. And just basically for the catch-up campaign is I think they have to set extra port. Nearest I think the community where people can easily come and get the vaccine. And as such, technically I think they are already fine with that. And I think before the campaign, district health authority must have already briefed them. And especially when you have a lot of vaccination, it's likely that you may get few we say A5, that means the cases following the vaccine. That's something to do with vaccine side effect. But then this especially for measles vaccines, this is very minimum. So these are all things that we already actually discussed. And even when they provide the vaccination, these are something that they have to look into, so that people, if they're suffering from any sickness related to the vaccine, then that needs to be immediately investigated and managed accordingly. And just to supplement what the Sangye was saying is on the challenge. The biggest challenge, at least for the Bhutan, is I think with regard to measles is because the India is our the neighbor country, and east west except the north, otherwise we all share the border with India. And especially the states that we share border with, I think the measles vaccination coverage is still not up to the mark. So because of that, there is endemic measles case across the border. So until unless our population is protected, with a good vaccine coverage, then we will keep on getting the measles cases like we have been getting for last 2 years. That's why because of this and with elimination, that we already had. So we want to now close the immunity gap, and once we achieve the overall coverage above 95%, then we should not really worried, whatever the outbreak or measles they have, because our people are well protected. Because 5% can be protected through the herd immunity. But just now, from the current finding is, although our vaccination coverage through routine systems says that it is above 95, but it still looks like there is a pocket of people. Either they are given a vaccine, but still there is a failure in seroconversion, and because of those, the build-up cohort. When you have no cases, of course people don't feel, but when you have suddenly a case imported from the other country, outside country, then once that transmission is setting, then people they get the disease and it spreads very fast. So because of that, I think this catch-up campaign should now close the immunity gap. And once we achieve that, then whatever the measles cases problem they have across the border, we should not really worry. That's why we are going ahead with this catch-up campaign, although it is not nationwide, but with these targeted areas, especially with the border towns and the remote places, I think people should now have adequate immunity built, and we should not see much case. Of course, it doesn't mean that you'll not get a measles case. We'll keep on getting, but unless we identify it as imported cases, the elimination status will be sustained.
Sir, last 30 seconds, I'll give it to you.
Okay. Thank you very much for this opportunity. So we are providing the vaccine free of cost. I would request all the eligible population in those targeted areas to avail the services accordingly. Our health workers are trained professionals. This is not a new vaccine. It has been there since 1979 in the country. So it's being vaccinated by the trained health professionals. So we have a surveillance system. If there's any adverse reactions or events following the vaccination, there will be a surveillance sensitive enough to pick up and then response, and all the emergency kits are ready. So I would highly recommend and request all the eligible population in those high risk targeted areas to avail the services accordingly.
Thank you so much. With this, we come to the end of the program, and I hope those of you who falls in this risk population should get this, try to get this opportunity. Thank you so much for watching.
So do you think the government of India will release the
How do you go about in solving this?
Did you receive any feedback from somebody?
A big leap from the normal thing that happens in
On the environmental science curriculum for